There's been, I think, with these newer drugs, the SGLT2 inhibitors, the GLP-1 receptor agonist, a lot of excitement now in the diabetes field because we truly have drugs that work. They're good at lowering glucose, but I think even more importantly, they are very good at protecting our patients against cardiovascular disease and renal disease. And so we're on sort of the ascending curve of the use of these drugs in the United States. And what I'm going to try to do is to give you an update of where we stand with these two classes of drugs. And I'm going to cover three aspects. First, I'm going to talk about the metabolic glycemic benefits of the SGLT2 inhibitors and the GLP-1 receptor agonist. I'll talk about the cardiovascular benefits, and then the renal benefits, because this truly is, these two classes are really very exciting, and Muhammad and I use these together. The original edict study, of course, was done with the GLP-1 receptor agonist, pioglitazone and metformin, and that was because the SGLT2 inhibitors were not available. But I think if we could redo the study, we would probably put an SGLT2 inhibitor ahead of metformin. So I showed this slide earlier, and I'm not going to go over it again other than point out that we have 8 problems to deal with, and we're going to have to use drugs in combination. And as I take you through what we've learned about the SGLT2 inhibitors and the GLP-1 receptor agonist, I'm going to show you where they work on the ominous octet. And then I think if you could come back to the previous talk, pioglitazone, you're going to see if we put these two classes of drugs with pioglitazone, we have everything covered. I actually could increase this to the egregious 11. I'm not going to do it. But the 3 other causes that I would put up there, we can maybe talk about them later, they'll also be covered as well. So again, I made this point earlier. I just make it again. We need to use multiple drugs in combination if we're going to get our people controlled. And we need to attack the underlying pathophysiology, and we need to start earlier. Now, the only negative thing I can say about the SGLT2 inhibitors and the GLP-1 receptor agonist is we have now shifted, unfortunately, away from glycemic control because we've focused on cardiovascular and renal complications. But you need to understand, if I keep the A1C less than 6.5, you don't develop the microvascular complications, okay? So we use these drugs oftentimes when people get complications, whereas if we started early and we kept A1C and risk factors under control, we probably could sort of lighten up on these drugs. So let's start with the SGLT2 inhibitors. Studies that we've done over the years were the first to demonstrate, and in fact, I invented this class of drugs using fluorescein many years ago, which then I worked with AstraZeneca, and in fact, dapagliflozin was the first of this class of drugs that came to the market. But interestingly, it came to the market in the United Kingdom in 2012 before it came to the U.S. So these drugs work on the kidney, and we know that 80% of the glucose is reabsorbed in the proximal tubule, and it's reabsorbed with sodium. And we know that in people with type 2 diabetes, there's hyperreabsorption of glucose in the proximal tubule. And what's strange is the higher your A1C, the more you're reabsorbing the glucose. So this is paradoxical. So we would, of course, like the kidney to be dumping the glucose, but unfortunately, the kidney, the higher A1C, the more it restrains, it hangs on to the glucose. And these drugs block that transporter, and you put the glucose out into the urine. And we also, many, 30 years ago, developed this concept of glucotoxicity. High glucose poisons your beta cell. High glucose causes insulin resistance. So the primary action of these drugs on the kidney, glucose comes out in the urine, blood glucose comes down, and then you get an improvement in insulin sensitivity and beta cell function. You get a very nice drop in the A1C. Because you're losing calories in the urine, what happens is usually in the first 6 months, there's about a 2 kilogram weight loss. And then because the drugs work on the kidney and the other anti-diabetic drugs work on non-renal mechanisms, you can combine them with all the other drugs. We get a nice decrease in blood pressure because we inhibit glucose along with its sodium. We get a little decrease in the intravascular volume, and then no hypoglycemia, another benefit of this class of drugs. So you are going to get a nice improvement in glycemic control, and we're correcting some of the cardiovascular risk factors and some other factors that I'm going to take you through. You might also expect cardiovascular benefit. So we can come back to the ominous octet, the primary mechanism of action of these class of drugs in the kidney. You see at 3 o'clock, glucose goes down, and secondarily in the upper left, we improve beta cell function. The bottom right, we improve insulin sensitivity in the muscle. Now, what about SGLT2 inhibitors in cardiovascular disease? When you see a type 2 diabetic patient for the first time, usually about 15% or so already will have symptomatic atherosclerotic cardiovascular disease. If you now would work them up carefully, you would find the other 70 or 80% already have subclinical disease. Why? This disease has been going on for a long time before you see the patient. And what kills our patients are not the microvascular complications, okay? If they develop kidney failure, we put them on dialysis, they go blind. What kills them is the cardiovascular disease. That accounts for 80% of the mortality. And the cardiovascular disease in people with type 2 diabetes presents 15 years earlier than in non-diabetics. And now that our diabetic patients are living longer, we're seeing a lot more heart failure. Heart failure with reduced ejection fraction, as well as heart failure with preserved ejection fraction. And then, of course, kidney disease is a big problem. It's the commonest cause of end-stage renal disease. And when you develop chronic kidney disease, whether you're a diabetic or a non-diabetic, the cardiovascular risk goes up. So you have the cardiovascular risk of diabetes superimposed the cardiovascular risk of chronic kidney disease. And so you just thinking about a drug that works on the kidney and has also cardiovascular protective effects, as I'm going to show you in a second, this is a great class of drugs. So the very first study was with empagliflozin. This is the EMPA-REG outcome study. The left panel is the MACE endpoint, which we talked about. Hazard ratio is 0.86. And then what was shocking and surprising and amazing was you didn't die. The hazard ratio was 0.62. And then in the far right, the first study showing this protection, hospitalization for heart failure. Now, I'm not going to take you through all of the other studies individually, but I'm going to try to put them here on one slide so that you can see that SGLT2 inhibitors, in my opinion, are all created equal. They all do a very good job. You can pick any one you want. So Declare is with dapagliflozin, that's in yellow. Canvas, this is canagliflozin. It's kind of fallen to the wayside in the United States. And then empagliflozin, the EMPA-REG outcome study. So if you look at the first three, that's myocardial infarction. The points are to the left, where the controversy has come in terms of cardiovascular death. So people have said, well, you get a much bigger decrease in the EMPA-REG outcome study. But remember, 100% of those people to get into that study already had to have a cardiovascular event. So they're the sickest people. Declare 2/3 of the people actually had only risk factors. They're the least sick. So in my opinion, that's why you see differences in canagliflozin was sort of intermediate. If you go down the list, you see non-fatal MI to the benefit, and then the surprising one up there is stroke, because these drugs do lower blood pressure by a systolic 5 to 6 millimeters, 1 to 2 diastolic. No benefit in stroke, and we still don't totally understand why that's the case. And then the dramatic decrease in hospitalization for heart failure, and then the bottom three, the renal composite with a hazard ratio about 0.55. So many, many benefits, very similar, in my opinion, with all three of these drugs. So this was the first dedicated heart failure study. This was carried out with dapagliflozin in people with reduced ejection fraction. The mean ejection fraction was 30%, and the primary endpoint was hospitalization for heart failure, cardiovascular death, or urgent care visit. If you look at the primary outcome to the left, you see a highly statistically significant reduction, hazard ratio 0.74. If you look at hospitalization for heart failure in the middle or cardiovascular death to the right, all benefited. So very, very positive results. And then came empagliflozin. So we have the first study in people with reduced ejection fraction to the left, and then more recently, empagliflozin in people with preserved ejection fraction. And you can see hazard ratios are pretty similar, about 0.75 to 0.8, and highly statistically significant. And then most recently, we've had dapagliflozin in preserved ejection fraction showing benefit. So for heart failure, and interesting, these studies had diabetic as well as non-diabetic patients. Clearly, a lot of benefit. Didn't make any difference whether it's people with reduced ejection fraction, preserved ejection fraction. So how do these drugs work? So at the level of the heart. So this is this figure is from a review article that Muhammad and I published. These drugs lower your blood pressure, as I said. So they're very, very important afterload reducers. And interestingly, in all the published studies, heart rate doesn't go up, suggesting that there's inhibition of sympathetic nervous system activity. We also go into a negative salt and water balance, although it's quite modest. So we get preload reduction. So we're both reducing the pre and the post-load. And these drugs, very importantly, have a dramatic effect to decrease aortic stiffness. So even though you measure the blood pressure in the brachial artery, it drops by 6, and the aorta may be dropping 8 to 10. So it's a big afterload reducing effect. We believe, and Muhammad's got some data, that there's a decrease in sympathetic nervous system activity. There are several studies suggesting that decrease in the left ventricular mass, as you see, you pre and afterload reduce, and there may also be specific effects on the myocardium. So I think that the major benefit are these hemodynamic benefits. Muhammad and I disagree a little bit about the role of ketones. We have a big study that's ongoing that's funded by the NIH to see if switching people to burning fat and generation of ketones, which are preferred fuel in terms of energy production, are playing a role. Now, there are a whole host of other mechanisms, and I'm just going to briefly take you through them. You'll read a lot more about this. These drugs improve insulin sensitivity. They, of course, decrease the glucose. You do get a little bit of weight loss. They lower uric acid, although I'm not a big believer in the uric acid hypothesis. They activate the angiotensin 1-7 system. This is the cardioprotective system. This is not the bad angiotensin system in the heart. They decrease inflammation, oxidative stress. They inhibit the sodium proton exchanger. And in a mediation analysis done by 2 different drugs, the increase in hematocrit has been purported to be able to account for 50% of the cardiovascular benefit. Remember, this is a statistical analysis, whether this is causally related or not. So no matter what you believe in, you can find something up here, okay? But I think the hemodynamic benefits are the more important one. So let's now take a look at the GLP-1 receptor agonist in terms of the drugs that are available, as well as the metabolic benefits. The first one that came was Byetta, and I actually directed the metabolic studies with Byetta. I'll show you the data in a second. And then there have been a whole slew of them to come. Liraglutide, once weekly, exenatide, dulaglutide, Trulicity, semaglutide, Ozempic, and then we have oral semaglutide, and I'll come back. The more recent one is tirzepatide. So here is my description of GLP-1 receptor agonist. The worst GLP-1 receptor agonist is a fantastic drug. That's the worst one. The next best one is a phenomenal drug. The next best one is an out-of-universe drug. That's Ozempic. And the next one is the one that takes you to the dark hole, the black hole. That's tirzepatide. And who knows what the hell is to come in the future. So you cannot go wrong with any one of these drugs. And Muhammad and I believe strongly they should be first-line therapy. Okay? So I mentioned this earlier. When you eat a meal, you make a lot of insulin. The glucose goes up. When I give the glucose intravenously, the insulin doesn't go up so much. The two incretin hormones are GLP-1 and GIP, and they account for 70% of the insulin that's secreted during a meal. Now, what are the benefits of these drugs? They very effectively lower the A1C, and they have a very powerful effect that I'll take you through in a second to preserve beta cell function. They also inhibit glucagon, so you're going to shut down hepatic glucose production. They're great drugs at lowering body weight, and now we can get up to 10 to 15% body weight loss. They correct, as I'll show you, 6 of the 8 problems in the ominous octet. No hypoglycemia, very good safety profile, except the initiation of therapy that's sometimes associated with nausea in about 15 to 20% of the people, and we got cardiovascular benefit. So this is now the original study carried out with Byetta. Have to give it twice a day. And when we design these studies, if you're on metformin, we add Byetta. You're on a sulfonylurea, we add Byetta. If you're drug naive, we add Byetta. And the Byetta or placebo was added for 30 weeks. So placebo did nothing on A1C, as you can see, that yellow line. And you add the Byetta, you see the nice drop, 1%. Starting A1C was about 8 to 8.1. Now, at 30 weeks, then the placebo group is switched to Byetta. A1C comes down, it stays down. If you're already on the Byetta, it stays down, and the benefit persists for 3.5 years. Now, Muhammad made this point. I made it earlier, and probably the most important point that can be made in this conference. If the A1C comes down and stays down, the drug is working on the beta cell to save your beta cell function. You can't measure beta cell function. If the A1C comes down and rises, the drug that you are using is not saving the beta cells. You have the wrong drug. So you can equate beta cell function with A1C. You don't have to do all these sophisticated studies that Muhammad and I do. Follow the A1C. It will tell you whether you're saving your beta cells or not. So these drugs work not through the standard glucose-stimulated insulin secretion mechanism. They work through the cyclic AMP system. The benefit of that is when your glucose comes down to normal, they stop working. No hypoglycemia. So your fasting glucose comes to 180, 150, 120, 80, 90. It stops there. No more insulin coming out. Okay. Now, they increase a gene called PDX1. This is critically important for the health of your beta cell. And if that gene gets downregulated, as it does in diabetics, your beta cells start to fail. When the glucose goes up acutely, your beta cells recognize that, and they kick out insulin. Your beta cells are blind to the rise in glucose, and they're blind to the rise in glucose because there's a downregulation of the glucose transporter system, and also for the phosphorylating enzyme, the glucokinase. And these drugs upregulate these early steps and restore the blindness. And then lastly, they decrease apoptosis. So tremendous effects on the beta cell, upper left. The gut, basically, I'm giving you back a pharmacologic dose to overcome the resistance of the beta cell. Number 3, I'm decreasing glucagon. Number 4, the rise in insulin and decrease in glucagon shut down hepatic glucose production. Number 5, I get you to lose weight. In my opinion, they are not direct insulin sensitizers. Some controversy with tirzepatide, which we'll get to, but the currently approved drugs do not directly improve insulin sensitivity. Indirectly, because you lose weight and I reverse lipotoxicity. I correct 6 of the problems. Fantastic, fantastic drug, okay? So these are the two most potent drugs that you have currently here. To the left is the change in A1C with SEMA versus DULA. SEMA is a little bit better than DULA, and A1C in this study about 0.4, and then the weight to the right, SEMA beats DULA. But in either case, these are great drugs, you know. There's nothing bad about dropping your A1C by 1.5. We'll all be happy to do it. But if I drop it by 2, that's even better. So as I said, we start with a fantastic drug and we only get better. So here are the tirzepatide data. The starting dose is 2.5, and usually you're on that for a month. And then we go to the 5, to the 10, the 15. And so to the left is the change in A1C. And in people with an A1C in the low 8s, I drop it by 2.2. So that means that half of your people or more are getting to 6.5. And then to the right, you can see at the higher dose, 11 kilograms of weight loss. So this new drug, which is a combination GLP-1 and GIP, is a very, very potent one. Now, what about GLP-1 receptors agonists in cardiac disease? So going from left to right is liraglutide in the leader study, semaglutide, sustained 6, then Bydureon, once weekly exenatide in Excel, and then the far right, dulaglutide in Rewind. And you can see hazard ratios that are, 0.75-ish to 0.85, all statistically significant, except for the Excel study. So the p-value is 0.06. Believe me, a p-value of 0.06 is no different from 0.05. So why was that one not positive? There was an enormous drop-in of SGLT2 inhibitors in the placebo group. And so John Buse has gone back and reanalyzed the data. If you take out the SGLT2 inhibitors, this becomes actually the most powerful of the studies. The point here is these are all good cardiovascular outcome trials. This now is the SUSTAIN 6 study. The primary outcome is 3-point MACE. You can see the hazard ratio is highly statistically significant to the left. If you look at MACE, 0.74, and the breakdown to the right, cardiovascular death didn't change in this study. Non-fatal stroke went down, non-fatal MI, and it looks pretty consistently that these drugs do decrease non-fatal stroke, whereas the SGLT2 inhibitors, as I pointed out, consistently did not improve non-fatal stroke. So this may be sort of an additive benefit where you get when you put the two together. Now this is oral semaglutide, hazard ratio is 0.79, and this was a smaller sample size, and what they showed was no superiority in terms of statistical significance, but I'm quite sure when they complete the big study, which is currently ongoing, they will get statistical significance. Right now, we have statistical significance with the injectable version. Now, how do you get these benefits? Of course, the kind of studies that I'm going to review for you here are animal studies because you can't do myocardial and coronary artery biopsies. But these drugs are anti-atherogenic, anti-inflammatory, anti-oxidative stress, and anti-thrombotic. There are documented that Dan Drucker has shown this, GLP-1 receptors present in the myocardium and in the vasculature. They're very good at promoting weight loss, so we're getting rid of lipotoxicity. They have a powerful effect to decrease postprandial lipemia, which we don't normally measure, and that's a major risk factor for cardiovascular disease. They lower the blood pressure. Now, let's come back to the kidney. SGLT2 inhibitors in diabetic nephropathy. So diabetic kidney disease is rising worldwide. And so if we look from 1997 to 2013 and continued, the years of life lost to chronic kidney disease is 90%. Years of life lost to diabetes is 67%. So what does that say? It says if you have diabetes, you're likely to die. If you have diabetes and kidney disease, you're even more likely to die. So don't control the glucose. That will help you. But make sure that you protect the kidneys, okay? It's the leading cause, diabetic kidney disease, of patients undergoing transplantation or dialysis worldwide. Unfortunately, the worldwide in the U.S. prevalence of diabetic kidney disease is rising. All other complications, myocardial infarction, stroke, retinopathy, are all decreasing quite dramatically. Even peripheral vascular disease is going down. Kidney disease going up, okay? So this was the original study with an SGLT2 inhibitor. It's the Credence study with canagliflozin showing protection of your kidneys. So there was a composite primary outcome, which was doubling of your serum creatinine, having the GFR, ending up on dialysis or transplantation. And you can see the hazard ratios 0.7, highly statistically significant. This was then followed by DAPA-CKD, and you can see that the curve to the right with DAPA-CKD pretty similar to the Credence study. The benefit of DAPA-CKD is it included diabetic and non-diabetic patients, and the non-diabetic patients benefited as well as the diabetic patients. Now, in most of these studies, there's a lower level of GFR. It's usually about 25 to 30. The patients are not recruited into the studies. So in the United States, in the package insert, there's always a statement that says the drug is contraindicated if your GFR is less than 25 or 30, depending upon what the entry criteria was. So this is an interesting analysis of the canagliflozin Credence study by George Bacris. So it turns out when the people came and they were screened, they got a GFR, and it had to be above 30 to get into the study. But then maybe they entered the study 6 or 8 weeks later, and then when they then entered the study, the GFR was less than 30. And many of the people down to 10 to 15. So what Dr. Bacris did was he reanalyzed all the data. So you can see the hazard ratio in the Credence study is 0.66 for protection against this multifactorial kidney disease endpoint. But it didn't make any difference if your GFR is less than 30, 30 to 45, 45 or above, you benefited. So in my opinion, you should be on this drug till you walk into the dialysis unit. You should not stop the drug. Of course, when you get into dialysis, it's not going to benefit. Also remember, when your GFR is 30 or 40, you're using the drug to protect the kidneys. You're not going to get such a big drop in A1C because less GFR, less filtered glucose, less drop, but you're saving the decline in GFR, keeping the person out of dialysis. Okay, so mechanisms by which these drugs work. So deranged glomerular tubular feedback, which leads to an increase in intraglomerular pressure. These are the things that cause kidney disease. If you want to stop kidney disease completely, don't let the A1C go above 6.5. You know, we start when the patient has complications, and then we worry. We have to have a drug. Well, what about just controlling the glucose? And then you don't have to worry. Hypertension, most important factor that will accelerate the decline in kidney disease. What is a normal blood pressure if you have CKD? Everybody agrees, 120 over 80, not 130 over 85, 120 over 80. Hypoxia, you're reabsorbing a lot of salt and water in the proximal tubule. You got to pump it out, and that's done by the sodium potassium ATPase pump. That requires oxygen, so the kidney is hypoxic. This leads to a whole host of fibrotic inflammatory reactions. Podocyte dropout. The podocytes are those cells that sit on the glomerular basement membrane with the foot process, protect the albumin, prevent the albumin from getting into the Bowman's capsule. Hyperglycemia has a specific effect to damage the podocytes. Albumin gets filtered, and then it damages the endothelial cells, the mesangial cells, the tubule cells. How many of you take care of a diabetic patient that's lean? I've been looking for one in San Antonio. I haven't found one in the last 5 years, okay? Most of our diabetic patients are overweight, 90% of them. And there's a diabetic kidney disease, there's an obesity-related kidney disease. Has nothing to do with diabetes. When you deposit fat in endothelials, mesangial cells, or tubule cells, it damages them. This is a big problem in our diabetic patients that's unrecognized. Tubulous hypertrophy, they release growth factors. It causes the glomeruli to hypertrophy. When the glomeruli hypertrophy, the pressure within the glomerulus, this is the law of Laplace. I'm sure you all remember this from your medical student days, right? The pressure within the glomerulus is proportional to the radius. And then, of course, genetics are very important here as well. So, what about the SGLT2 inhibitors? They correct 6 of the problems. They're going to be fantastic drugs for protecting your kidney. So again, if you understand the pathophysiology, you understand why the drugs work. And these are really incredibly powerful drugs. Now, we are really at a very good stage. We got 8 problems. There's an ominous octet for the kidney. There are 8 problems we have to deal with. ACEs and ARBs, but you need to get them up to the maximum dose. Most people are not on the maximum dose of ACE and ARBs. Then you can add the SGLT2 inhibitor. And now we had the non-steroidal mineralocorticoid agonist. It's like feninerone, a very good drug. And and that's approved in the US. And then GLP-1 receptor agonists, I think, are also going to turn out to be protective, but not all GLP-1 receptor agonists. So this is a meta-analysis of the studies that are out there. And you can see in that hazard ratio of 1, which is the white line, there are a couple of yellow dots to the right. And then there are a couple of yellow dots that are close to the line. And then you can see in rewind and amplitude, there are a couple of dots to the left. Unlike SGLT2 inhibitors, which I think all of them are created equally, for the GLP-1 receptor agonist, I think you're going to have to look at each one individually, because I think some will benefit and some won't. The flow study is going on with Ozempic. I've seen some preliminary data. I believe that it is likely to be a positive study, but we'll get a readout of that next year. And so we potentially will have 4 drugs that will work on the kidney to save your kidneys. So I like these 2 classes of drugs together. As I said, Muhammad and I, if we had to do the edict study again, I think we would have used SGLT2 instead of metformin. This is kind of a contrast of the 2 drugs, and if you were to use them together, what you would expect. So if we were to look at the MACE endpoint, okay, intrinsic cardiovascular disease and heart failure, both of these drugs classes are very good, so I would expect a somewhat additive effect. In terms of blocking the atherogenic process, that's where the GLP-1 receptor agonists work. In terms of improving myocardial function, that's more where the SGLT2 inhibitors work. But strictly blocking the atherogenic process, I don't think we get an additive effect. For diabetic kidney disease, if you pick the right GLP-1 receptor agonist with any of the SGLT2 inhibitors, I think you would get an additive effect shown in the orange. Glycemic control, they're both very good. They work by different mechanisms. One might expect an additive effect. They both improve insulin sensitivity, somewhat indirectly. And I think if you put them together with the weight loss and a reversal of glucose and lipotoxicity, you'd see a benefit. GLP-1 receptor agonists have such a powerful effect on the beta cell. I think if you put the SGLT2 inhibitor with it, you won't get any more of an additive effect. And then lastly, in terms of body weight, the GLP-1 receptor agonist really pretty powerful here. If there's an increased additive effect, it would be pretty slight. So in conclusion, both these classes of drugs are very, very good at lowering your A1C. They're good at lowering the blood pressure. They're good at decreasing the body weight. And a major benefit is they don't cause hypoglycemia. Of course, if you're using with the sulfonylurea, and I don't use sulfonylureas in my practice, then you have to worry. If you're adding them to insulin, you have to be a little bit more carefully. You can use them with each other as well as in combination with any of the drugs that are out there. No sense of putting a GLP-1 with a DPP-4 inhibitor. They both decrease cardiovascular events. So the data that are out there, I think, suggest that when you add a GLP-1 to an SGLT2 or vice versa, you get all of the benefit of each drug. So you can use them together and get an additive effect. They work for preventing, but you got to be careful about the GLP-1s here. You got to pick the right one. They prevent the progression of diabetic as well as non-diabetic kidney disease. In my opinion, these should be drugs that should be considered for first-line therapy, and I actually use triple therapy with these two plus pioglitazone in all of my patients. So that's the last slide, and a brief run-through. Of course, you could spend hours talking about this class of drugs because there are so many benefits. So I'll stop at this point, and if there are a couple of questions, if we have time, I can try to answer them, but I'll also be around for a little while later.
Thank you very much, Dr. De Frenzo. Any question? No question? Actually, I have one question. Okay.
Thanks a lot for this interesting presentation, and would ask about a comment you said in the lecture that diabetic nephropathy as a complication of diabetes is increasing worldwide in comparison with other complications of diabetic retinopathy and other cardiovascular. Why? There is an exact explanation for this process?
I think there are a couple of things that are a factor here. The number of diabetics are going up dramatically worldwide. So the total number of people are going up. And so even though the percentage of people who are developing diabetic kidney disease may not be going up, it's a percentage times a growing mass of people. The other thing is that people are not using these drugs. Unfortunately, this is pretty shameful in the United States. 50% of nephrologists do not prescribe SGLT2 inhibitors. That's like inconceivable to me. So I think that we will start to see things tailor off, whereas we've done a very good job. We use antihypertensive drugs, we use antilipidemic drugs, antiplatelet drugs. So these are decreasing the incidence of, say, cardiovascular complications. And we've been using these drugs now for a long period of time. The SGLT2 inhibitor class is relatively new, and they're just starting to catch on. And eventually, I think we'll see this big increase start to slow down.
أي سؤال تاني يا شباب؟ شاعوا الشباب فيش أسئلة. No question? No question. I have one small question about the GFR and SGLT2. If the patient have end-stage renal failure, it works SGLT2 with him?
And it depends what you mean by end
GFR below 30.
Oh, yes. Yeah, absolutely. Yes. As I said, you should be on these drugs right down till you walk into the dialysis unit. So even if your GFR is 10 or 15, the data support being on the drug. Once you end up on dialysis or getting a kidney transplant, I mean, once you end up on dialysis, there's no benefit to be on the drug. Once you have a kidney transplant, there actually are a couple of studies that are published that's suggesting that these drugs actually may be beneficial to the transplanted kidney, but that's more experimental than, I would say, well-designed studies with approval by the FDA.
Any question? Thank you very much.